Well, good morning. Again, it's a pleasure to welcome Justin Smith from UVA, who's going to visit us. Justin is one of the most accomplished people in spine world, in academic neurosurgery. You don't need to read his CV, you can just weigh it. It's 260 pages with small font. And very impressive accomplishment at really mid-career level. He grew up in Utah and then moved several times, but the first move was essentially going to Hopkins for undergrad, then went to Mayo for med school, UCSF for residency, then did 2 spine fellowships, one with Chris Shaffrey for adult and pediatric spine and deformity, and then was one with Rick Fessler at Northwestern for minimally invasive spine surgery before he went back to UVA, where he's been there since 2007, correct? 2007. And Justin has many national involvements, but closest to me is, of course, he runs the membership committee in the AANS. And I'm looking forward to him continuing doing that while I'm president next month. So Justin, please talk to our wonderful group here about adult deformity surgery and how to avoid complications.
Yeah, I figure it's a good continuation of M&M conference, right? So that's how to avoid the complications. Well, thank you. It's a very kind introduction, and it's a pleasure to come visit and share with you my thoughts on strategies to avoid complications in adult deformity surgery, which is an area of my particular interest. Not so much just to add up complications and publish them, but part of my career has been studying complications, especially the common ones and the most impactful ones, so that we can find ways to try to mitigate their effects and reduce their occurrence, which is, I think, the power of studying complications. And I think the power of having the conference you just had, M&M, is not so much to point out the failures, but to look at the failures and figure out how you can keep them from happening again. These are my disclosures. I do some work with industry, consultants, development work, but I think more important in this group, the disclosure I should really give is that I actually used to be interested in brain research. I think that's probably more relevant. As Jacques said, I started at Hopkins in undergrad, and I wanted to be a radiologist. I did PET research over at the medical school, looking at cocaine analogs in Parkinson's disease, and I was definitely going to be a radiologist. And I did all kinds of papers on kinetics and opioid receptor mapping. And then I moved to Mayo Clinic and I did my PhD work there in brain tumors. And I'm part of the reason you get bombarded with the 1P19Q question on your boards. I had great success in the lab there, and suddenly I wanted to become a brain tumor surgeon. You know, that was my destiny. No longer radiology. I wanted to be a brain tumor surgeon. I moved to UCSF and worked with Mitch Berger on a number of studies, the extent of resection and low-grade gliomas, which is I think it's been cited over 1,000 times. A very powerful study. So I was dead set on becoming a brain tumor surgeon. Then I discovered something really kind of interesting and kind of charming, if you will, these kinds of cases, right? The disasters. And you can take these people apart. They often come in and they're so highly impacted by their disease. They just some of them just don't even want to live anymore in the situation that they're in. And in the course of a day, you can change their lives dramatically. You can take their spine apart and reconstruct them and really give them their lives back potentially. So my journey through to now mid-career has been a little bit convoluted. I started out wanting to be a neuroradiologist, evolved slightly more where I wanted to be a brain tumor surgeon. And then finally, I feel like I'm fully evolved as a complex spine surgeon and have never looked back and never regretted.
Thank you. That was a brilliant lecture. Thank you.
So my journey has been, one of, not a direct path to spine, but I'm very happy with the choice I've made. I think I've had an opportunity to make an impact in the field. Part of the reason spine is so impactful.
Did you lose your facial hair and your body hair in that transition?
Yes, that's part of it. Part of what makes spine so interesting for me is how the population demographic is changing in the US. And you can see these plots here. By 2030, believe it or not, 1 in 5 in the US will be at least 65 years of age. That's where we are a graying population. And you can see we're still in the upslope here. We're still moving upwards in our aging. And so when you have a population that's shifting like this, you have to look at it and say, well, what health problems affect that older population that's going to be expanding dramatically? Well, in the past, our expectations as we got older, I think were less. We didn't have as long of a life expectancy. And when grandma got to, I don't know, 70 and she started having too much pains, we just parked her on the porch and let her rock her last years out. Now people are living a lot longer. And this is a gentleman who's 100 years old, skydiving for the first time, and you've got an 80-year-old figure skater, and I don't know what these others are doing down at the bottom. They're having a good time, and people want to live longer and stay active longer. Their quality of life they want to extend into their 80s, 90s, or even beyond. And I heard on the news that there's a prominent researcher who has said that the first person to live to 150 years of age is alive now, has been born. So they're predicting that people are going to live even longer. And one of the things that's very prevalent in older patients is spinal deformity. 2 different studies have estimated that a rate about 60 to 70% of elderly patients will have some degree of spinal deformity. And there's a large range of deformities in adult spine. In pediatric population, they're a little more limited. Most of them are going to be adolescent idiopathic scoliosis. There are some other varieties of congenital and early onset, but in adult spinal deformity, there's quite a variety. You have the adolescent idiopathics that are left over into adulthood. You have senile kyphosis. You have lumbar scoliosis or thoracic scoliosis, and you've got all the wonderful ones that we create as spine surgeons in the whole iatrogenic category. Fortunately, in the vast majority of adults who have some degree of spinal deformity, it's going to be incidental, and it's not necessarily symptomatic. It may only require education and follow-up. They may get sent to you because they had a chest x-ray that showed a little bit of curve in their spine or something minor, and not all that obviously needs to be addressed from a surgery standpoint. And then there's the group of adults who have relatively mild symptoms that are at this point at least able to be treated with non-operative therapies. And then there's the third group, and they're the ones that are often in our clinics, those who have significant pain and disability that's not benefited by non-operative therapies. And those are the ones who are often wanting options for surgical treatment. When I joined the spine field in mid-residency, there really wasn't a lot out there on outcomes. It's pretty limited, which is part of what excited me about it, just because it was the Wild West. There was really not a lot to find in the field at the time. And since then, there have been a number of studies that have shown the surgical treatment for adult spinal deformity can actually be quite effective. This was one of the first ones that I did when I came to UVA, looking at risk-benefit analysis of adult scoliosis. The idea was, people would say, why are you operating on these people in their 60s and 70s? Are you really helping them, or are you just putting metal in them? And what we did is we provided over 200 adult spinal deformity patients that had all been treated operatively with minimum 2-year follow-up into younger, mid-age, and older age groups to see how they would be impacted by complications and outcomes. In the top graph, you can see, not surprisingly, complication rates go through the roof. The young group all the way up to the older group, a 4-fold increase in the complication rates. That said, if you look where the young, middle-aged, and older groups start, the older patients are more impacted by their deformities from a disability standpoint and from a pain standpoint. And if you look at how much you improve them, these are the 2-year bars on the right, you can see the delta, the amount you're improving the older patients is significantly greater than the younger patients. So despite facing these highest risks of complications, the older patients actually stand to potentially gain the most from these surgeries. The conclusion is that you shouldn't necessarily write off these older patients. You should be judicious in who you choose to operate on, but not necessarily write them off because they're older. We've also done several studies since then showing that the outcomes are better in operative versus non-operative treatment. And this is a study done through the International Spine Study Group, or the ISSG, that I'm a member of and have been one of the founding members, in which we actually compared in a matched cohort operative versus non-operative treatment with 2-year follow-up. And in the operative treatments, operatively treated patients across all these measures of outcomes, the ODI, which is a disability index, the SRS-22, which is a deformity specific outcome, and then of course you have the back and leg pain scores. And we did a number of outcomes measures. These are just the 4 on this slide that I'm showing. But in each case, the surgically treated patients had marked and significant improvement at 2 years compared with the non-operative patients, which if anything had some degradation in their symptoms, but certainly no improvement over the time. This is probably one of the more landmark studies. This was led by Keith Bridwell, who's at WashU. We actually took some of that data from that risk-benefit study that I showed you earlier and used as preliminary data for NIH grant to fund this. Was I think it was $15 or $20 million grant, and across sites from the US. A prospective, multi-center, dual-arm, randomized, and observational cohort study to compare operative and non-operative treatment. The NIH insisted on a randomized arm, was not the choice of the investigators. They insisted on a randomized arm. And you can imagine if you're a patient coming into clinic and someone's essentially flipping a quarter and deciding if you get, massage treatment and physical therapy versus a T4 to the pelvis, they're going to flip a quarter and tell you, randomize you. A lot of patients weren't so eager to be randomized. So it's a little hard to get the patients to randomize. And this is the 286 patients enrolled. And you can see what happened here in the crossover rate. So patients who were randomized to non-operative treatment, by 2 years, 2/3 of them had crossed over to surgery. So you kind of get the feel there that non-operative treatment was not successful, but it really complicates analyzing the randomized, as randomized data. And so we ended up analyzing it as treated. And we had 90% overall 2-year follow-up, which is really quite good when you consider these are operatively treated and non-operatively treated patients. Non-operatively treated patients are notoriously hard to get to follow up because you're really not doing as much for them. They're not as tied to you as those that you've operated on. And so they're harder to get to follow up for routine outcomes measures. And you can see this is the as treated randomized cohort. You see this marked improvement with surgery. And then you see this kind of just puttering along without any real major change without surgery. And keep in mind, these you can say, well, they're not changing, isn't that a success? Well, they've come to a surgeon, they're clearly not happy, they clearly have symptoms. And you can see they're actually starting out not too far off from where the surgically treated patients were starting off as well. So these are probably just patients who have just chosen to not have surgery for various reasons, but they're not necessarily doing well. And this is the as treated observational cohort. So you can see they're significantly improved with surgical treatment as well. But you might say, well, 2 years, what those high complication rates and with how much these surgeries cost. These are very expensive surgeries. There's a lot of metal that goes in. There's a lot of resources that go into these patients. Is a 2-year outcome adequate? And certainly for cost benefit analysis or qualities and all the cost effectiveness analysis, 2 years isn't going to be enough because time is in the denominator. And if your cost is $200,000 or $300,000 for a surgery, you're only dividing it by 2 years. Your benefit per year per cost is high. So it's going to be, or the cost is going to be high per benefit. And so we looked at the same cohort following them out to 5 years. And we again analyzed them in the as treated groups. 74% 5-year follow-up, which is really, I think, quite amazing. This is unprecedented. The AO has a SCOLI risk study where they have 5-year follow-up of, I think, 21%. So 74% 5-year follow-up is really, I was impressed with that. And so what we had before is that we had this 2-year follow-up, which you can see in the graphs there, where we had no idea what would happen, because these patients have surgery. Sometimes they get revision surgeries. They might degrade over time their benefits. We didn't know how's it going to play out. Maybe the non-operative patients would suddenly rally and start doing really well at 5 years. Well, this is what happened. Stayed the same. No evidence of degradation in the outcomes of the operatively treated patients whatsoever. It stayed steady out to 5 years. And if you look at SAEs or serious adverse events, most of those were revision surgeries in the operatively treated patients. Those patients who had an SAE still had greater improvement than the patients who never had surgery at all. If you started getting to more than one SAE, so if they had multiple revision surgeries, they still did better on average than the non-operatively treated patients, but the benefit, the treatment effect started to degrade. So even with a revision surgery, they still did much better. But is 5 years enough? This is a really, these are a big investment in these surgeries. So right now, this is one of the things I'm actually working on now is the 8-year outcomes. This is the final time point for this NIH study, looking at 8-year outcomes. And we're still at 72% follow-up, which I think is just astronomical. That's unprecedented. And no study's been done like this before. This is a new path. And so now we're looking at these patients at 8 years. So after 5 years, you can see where they were, still moving along. And you might say, well, these are older patients, right? So they're going to age too, right? So you think, well, maybe they're going to be getting older and the effects of surgery are going to diminish, and maybe they'll have some more revisions and they're going to end up being worse. No hint of that at all. They were durably maintained out to 8-year follow-up. So this is arguing strongly in favor of the benefits of surgery. And again, the patients who had an SAE still had greater improvement than those who never had surgery at all. So this is really strong data that supports that that surgery is a potentially good option for these patients. It doesn't mean every patient with a deformity needs to have surgery. It's a highly personal decision. But what it shows is that the benefits of surgery are tangible, and durable. But you have to come back to the price the patient's paying for these surgeries. And one of the prices, it's not just money, it's the complications. And that's what has my interest, because you can see 71% complication rate in these older patients. So you have to put that into context. And that really is a risk-benefit analysis, which the conversations that I have with my patients in the clinic all the time about what can you gain from surgery and what are the risks that you're going to face? And is this the right decision for you? And so one of the areas that I mentioned at the beginning of the talk that I'm very interested in is complications. And this is one of the early studies we did through the ISSG looking at minimum 2-year postoperative complication rates. And as mentioned, 70% in this population. This is a different population, the risk-benefit study I showed you earlier, but you're seeing something very similar, 70% overall complication rate. And that doesn't mean that 70% of patients had one complication. That means 70% of patients had at least one. They had from 1 to 10 complications. 30% skated by without any complications, but those 70% of patients bore the brunt of all the complications. So if you look at where those complications lie, the major complication categories here are listed. And if you break it down, there are 4 categories that account for about 70% of the major complications: implant, radiographic, infection, and operative. So those are your key targets where you're going to want to zero in and say, what are those complications? What can we do to change that and improve those rates? We've looked at this in other ways too. This is a study from Peter Pashas through the ISSG. We looked at revision rates in 243 spinal deformity patients. We excluded wound complications. That's wasn't the focus of the study. We're looking for other reasons for revisions. Number 1 was rod breakage or pseudarthrosis, so failure to heal, and the instrumentation fracturing. Proximal junctional kyphosis, and the third was other implant related. So you're seeing mechanical complications are number 1, 2, and 3 in these patients. This is one from our fellow from a couple years ago, Elias, who wrote when he was with us, when we followed out to 4 years in the ISSG study. I showed you the 2-year data for outcomes and the 2-year data for complications. This was now the 4-year data. And what we found is if you look at the population, 54% of the patients had already had a prior spine fusion at the time they were enrolled in our study and have what we considered their index surgery. So they're already starting out, more than half of them, with a previous fusion. So you're already seeing the impact of revision surgery or the rates of revision surgery. And at 4 years, 27% or more than 1/4 had another revision surgery beyond the index surgery that they'd had when they'd enrolled in the study. So you're saying that the revision surgeries are a really major problem in these patients. And so to give an example, this is a patient who came into my clinic a couple years ago now. This kind of typical Monday morning first patient in my clinic, 67-year-old woman, 8 previous spine surgeries. She has groin pain, leg pain, progressive lower extremity weakness over the last 2 months. She says that she can stand for a few seconds with a walker, but otherwise she's in a wheelchair. And she says, oh, by the way, over the last couple of weeks, I've had progressive and significant bowel and bladder incontinence that I can't hold anything anymore. And we asked her why she didn't go to the ER when she developed that. And she just said, oh, well, I knew I had this appointment coming up, so I just waited. So it's nice, very nice of her. You can see her alignment here. She's grossly sagittally imbalanced. On exam, you can see her strength it's real. I mean, she's got 1s, 2s, and 3s in her legs. She's weak. She's has a hard time moving her legs, and she also has saddle anesthesia. And she's diabetic, of course, and all the other things that go with that. And if you look at her, she's a great example of revision surgery and where our surgeries go wrong. You can see she's had multiple extensions here, probably for junctional failures, at least a couple, if not 3 extensions. I don't know who thought it was a good idea to do a lateral and then a unilateral screw at the top of her last failure, but that's what they did. And then someone did the Hail Mary and did a spinal cord stimulator here, thinking that might solve everything, and unfortunately it didn't. She also has a flat back. If you measure her out, her pelvic incidence is fairly high, and she has almost no lordosis. And so she's been flat backed, and that's probably partly why she keeps failing above, because they flat backed her initially, and then she breaks down the level above, and then extend her up and flat back her more, and then it just progressively gets worse. And now it's culminated in a pretty significant problem for her. You can see on her CT imaging, her screws have pulled out at the top and eroded through the level above. And she's got a large disc herniation up here at the top, very large. You can barely see where her spinal cord is on the MRI. It's just pancaked in there. And that's probably why she can barely move her legs. And this disc isn't just a classic typical soft disc. You can see probably some of it has been there for some time because it's ossified. So you got this giant ossified central disc pinning the spinal cord against the lamina at the level where the screws have failed and she's breaking down. So what do you do for this patient? This is one where you could show it in a conference and discuss at length, and you could show it to a room full of 10 spine surgeons and get 50 opinions. How do you treat this? But we'll come back to that. Instead, I want to use her as an example of how do you look at reducing the risk of revision. So this lady clearly is going to need surgery. There's no way around it. She's landed in your office, and you can't take the time to optimize her, make her lose some weight and various things. She can't move her legs very well, and she's incontinent and saddle anesthesia. Yeah, she needs surgery. I think most would agree that something needs to be done. So when you're planning her surgery and what you're going to do, the last thing you want to do is create a cascade where you're going to do 10 more surgeries on her. It would be nice to think about where her revision risks are for the surgery you're planning and try to reduce those. And so she doesn't keep coming back for more and more surgery. So if you look at her, probably one of the number one things or areas where she's going to fail is going to be rod fracture. She's already broken her screws down at the bottom, and she's pulled her screws out at the top. Rod fracture rates, this is from that NIH study that I showed you earlier. This is 5-year data. And this is from our two fellows at the time, Juan Sardi and Bruno Lazaro, helped put this together. And this was looking at the rod fracture rates at 5 years. These are all patients, one thing I should add, these are all lumbar scoliosis patients, primary cases. None of these are revisions. This is first time around for all these patients. So they aren't big PSOs. They're mostly coronal corrections. They haven't had a previous fusion before. So they should be your best case scenario patients. And there are 160 patients surgically treated, median 5.1 year follow-up. Rod fracture rate at 2 years, 11%. At 4 years, 24%. If you model it out with the cases where you have some of them had longer than 5-year follow-up, 49% rod fracture rate. That's almost 50-50 chance. And if you only follow those patients out to 2 years and say, oh, they did great, and then you pat yourself on the back, 73% of those rod fractures were occurring after 2 years. So if you don't follow these patients longer, you're not going to really see the impact. And about 2/3 of these were revised as of last follow-up. So not all of those rod fractures needed revision. If they were unilateral and non-displaced, some of those were not symptomatic, they may be incidental, but 2/3 of them had been revised. So you figure 2/3 of half of the patients is quite a few revision surgeries. So how can we improve this? And this is something we've been working on through the ISSG for some time, and other investigators have been too. But you can come up with different broad constructs and different strategies to try to reinforce across the more vulnerable areas of the spine. And this is a study led by Manish Gupta through the ISSG, where we looked at different techniques for supplemental rod constructs and looked to see what the rod fracture rates were associated with those different constructs. A couple of the classic ways of reinforcing rods. One is to put side-to-side connectors, kind of above and below posterior column osteotomy levels, and then run an extra rod. And so you can have, we call this a 3A because there's 3 rods, and this is an accessory. It's attached to one of the primary rods to reinforce. You can do that bilaterally too. There's another type of rod called a satellite rod, which is often used across a PSO, so a 3-column osteotomy. And the idea here is that if you bend your rod, your primary rods really sharply to capture that sharp angular correction across a PSO, you're going to really notch that rod. You're going to potentially compromise it if you're bending it really sharply to dip down and capture the heads of those screws at the angular correction. But if you put a separate rod in across just above, one level above and below the PSO, that short rod doesn't get bent very much, and the primary rod can sweep over the heads of those screws and not be bent very much either. And so the idea was that this would introduce less fatigue to the rods and improve the fatigue life of the rods. And so we looked at rates of rod fracture with these different strategies. If you just use 2 rods, this is out to 2 years. If you just use 2 rods, the rate of rod fracture was 21%. With an accessory rod, so rod attached to the sides with side connectors, it went down to 11. And with a satellite rod, at least at the time of this publication, was 0%. So none of them had fractured, at least at that time. We've looked at this through our the UVA series as well. Emily was a medical student who worked with us, and Tom and Tony were residents. And we looked at our rod fracture rates. These are my cases and Chris Shaffrey's cases. If we use 2 rods for our deformity correction, 20% rod fracture rate, and these are all comers. So these are revisions cases. This is the complicated cases. If we added accessory rods, it went down to less than 4%. So a pretty dramatic reduction in the rate of rod fracture by adding supplemental rods to the construct. And this has been shown at other centers too. This is Chris UCSF, where he looked at his series of PSOs, so the 3-column osteotomies, and if they had 2 rods, their rate of rod fracture was 36% at 2 years. Accessory went down to 13%, satellite 14%. And they found the independent factors that were protective for rod fracture was adding an accessory rod, using satellite rods if there's a PSO, and then using BMP or osteobiologics. So it's still important to get that fusion. You can put a ton of metal in there, but if you don't get the fusion, the metal may eventually fail. And we're actually doing some studies through the AO Knowledge Forum now, where we're looking and mining data for longer term follow-up on supplemental rod constructs to see if we're just delaying the inevitable, but you still have to get your fusion. And another study, this is Larry Lenke's study from Columbia, where they show that if you had 3 or fewer rods across the lumbosacral junction, that was an increased risk of rod fracture. So again, arguing for supplemental rod constructs. Something I started doing about 5 years ago was to add an extra iliac bolt as an anchor for an accessory rod. And I started doing it unilaterally, and then I started doing it medially, and then I started doing it bilaterally. And you can see it's 4 iliac bolts. Each iliac bolt has a separate rod that attaches. So instead of anchoring my accessory rod to the primary rod at a point probably where it's more vulnerable down at the lumbosacral junction and putting more stress on the primary rod, instead I ran separate rods up beyond the osteotomy levels to anchor and to reinforce. And it's pretty easy to put a second one in. Once you put a first iliac bolt, the second one just slides right along the first one. Pretty easy to do. And one of our residents, Connor Berlin, and our 2 fellows currently have put this together of my series so far, 82 patients, median 2-year follow-up, only 1 rod fracture. And these are disaster cases. These aren't the nice little sweet cases from the NIH study where none of them had fusions before. These are revisions, PSOs, all kinds of things. 1 rod fracture out to 2 years in these 82 patients. When I was showing you before, rates of 10, 20, 30%. Then the 1 fracture was incidental, asymptomatic, has not been revised, may never need to be revised, and it's actually above the level where the iliac accessory rod is. So is this the answer? I don't know. I can't tell you this is the answer. 2-year follow-ups, maybe not quite enough. We need longer, but this looks like this is going to get accepted into JNS spine. We just sent the revisions back, which were pretty benign. So in this woman, when we revise her, we're going to want to maybe add some extra rods to her to try and reinforce. So that's one thing we want to look at. The other is proximal junctional failure or kyphosis. And this is a real major problem in these constructs. I would argue that this is the biggest unsolved problem in adult spinal deformity surgery is proximal junctional kyphosis and failure. And you can see a great example of that in the image down here on the right. You do a beautiful surgery, you pat yourself on the back. The first time you get standing x-rays on follow-up, they've already bent over and fractured at the top of their construct. And it's very discouraging, but unsolved problem. A lot of ideas have come about, the semi-rigid rods at the top to reduce the stress, maybe putting your screws in at the top level percutaneously or transfascial so that you don't disrupt the soft tissues as much. Maybe vertebroplasty at the upper vertebral levels. None of these have been shown to work.
Justin,
Yes.
sorry to interrupt, look, this is beautiful work, and of course, the kinds of patients you all deal with are extremely complex, and you've shown some wonderful examples, but, don't you think we're missing a little bit of the whole point of having a spine, which is that it needs to be flexible? And, when you instrument a spine to that point, well, of course, to me, it's obvious that it will break at the level where it can move. It's not a surprise, it's an essential consequence, because the body still wants to move, right? And so instead of just the concept of potentially flexible rod at the top, why not make all the rods semi-flexible? And why not invest very majorly in new material properties that can be rigid and flexible on demand?
Because ultimately,
I realize that's a long journey, but
yeah,
you're not going to help these people just with
yeah.
12 level of instrumented fusions. I don't think,
Yeah. If you look at it, the proximal junctional failure rates where they actually need a revision are probably 10%. So it's not, so 90%.
Or the other ones break their odds. So, you just pointed out that half the people break their odds within 3 to 5 years, right?
Yeah. But the issue is you have to eventually get the bones to fuse. If the bones don't heal together, everything you put in will fail.
What I'm getting at is, why do you want the bones fused? I mean, shouldn't the whole goal be to try to restore the normalcy?
That would be great. I don't think there's anything on the horizon for that. You have the instrumentation bone interface, and that will fail if you don't have the bones healed, because there's so much stress on the spine just through daily activity and use of the spine that anything you put in there will fail unless your bones heal or fuse across it. Could there be some breakthrough? That's a great aspiration, but I don't see anything on the horizon for that.
Well, you lead this field, people like you are the ones who can make engineers motivated enough to design things.
Yeah, but they've tried all kinds of things where they'll put flexible, like bending rods at the top and all that, and guess what happens? It fails. The screws pull out the bone interface.
Yeah.
So I agree with you. And there's lots of money being put into people working on things like that or resources, but that has not materialized. It's just aspirational. But lots of things have been tried. There are a number of patient factors that have impacted junctional failure. Body mass index is one of the big ones. Comorbidities, frailty, osteoporosis. These are often patients who have softer bone, and older age. So some of these factors you can't really change as far as their risks of junctional failure. Some of the things that I've learned over the years that I think have helped to reduce my rates of proximal junctional kyphosis, I've listed here, and I'll run through these quickly here. The first is not overcorrecting their sagittal alignment. You can imagine, so this is a lady here, sagittal imbalance. She ended up getting a PSO, looks beautiful, probably overcorrected here. You can imagine if someone's pulled back and overcorrected, what's going to happen? They're going to tip over at the top. And so one of the big factors is to not overcorrect these patients in the sagittal plane. And I think some of the early goals that were published for alignment were published for all age groups and all types of deformities and applied to generally. Then we probably did overcorrect a lot of patients, and it probably increased the rates of junctional failure. And this has been shown in big studies. This is one from the ISSG, looking at if you overcorrect a patient, the ones who developed the proximal junctional kyphosis were the ones who were sagittally overcorrected. And this has been shown quite objectively in large series. So one no-no is overcorrection. Another is how you bend the rod at the top of the construct. I never want to reduce the rods into the heads of the screws at the top couple screws. I want the rod to fall into those heads at the top. I'd rather put a little kyphosis in the top of the rod so that it contours and matches the curvature at the top of the spine. And this has also been shown objectively in studies of how that rod is contoured at the top. If you leave it in a lordotic position, it's going to put more stress on the screw bone interface, and it's going to be more apt to lead to failure. So how that rod is contoured at the top seems to make a big difference. Another is where you restore your lordosis. We used to do a lot of PSOs, or the 3-column osteotomies, in flatbacks up at L2, L3 because it's a lot easier. The nerve roots are more forgiving, the vertebral bodies are a little smaller, The depth you're working at through tissues is less, but that's not where the physiologic lordosis is really needed. Most individuals have the bulk of their lumbar lordosis down from L4 to S1. And if a patient has a high pelvic incidence and they need a really large lumbar lordosis, it might shift up to L3. But most patients need their lordosis down at L4 and L5. And so a lot of PSOs have now shifted down to L4 and L5 to try to get the lumbar lordosis restored where it physiologically should be. So if you restore it too high up and there's an abrupt angular change at the top, up near where your screws are ending, there's going to be more stress and making it want to fail at the top levels. And that again has been shown objectively in multiple studies. And the last is an area of interest of mine is ligamentous support. So over maybe 10 years or so, this has kind of evolved with different techniques of adding a tether or junctional support where the instrumentation ends to the levels above. So threading a tether through the spinous processes of the one or two levels above where the screws end and anchoring it down to the rods or anchoring it to the bones below, again, as a buffer to try to take some of that stress out of the junction at the junctional level. And we've looked at this in our series at UVA. This was one you can see Professor Quinn here is one of the authors here when he was a fellow at UVA, along with one of our residents, looking at tether use in reduction of PJK. And what we showed is that by adding these tethers, it does help buffer and reduce the stress at that junction and help reduce the risks of failure and need of revision. And this is getting at kind of the point that was made that if you can, I guess to some degree, this is maybe one step in that direction of providing some flexibility, at least at the top of the construct, and reducing that stress may have benefits down the road. This was adjusted for all of the potential confounding factors. And this is another really nice study. This is one from Eric Kleinberg, who's now here. This is when he was at UC Davis. He looked at this same thing. He had 20 patients, adult deformity, no tether at their junction, and 23 with a tether. So relatively small numbers, but he looked at 2-year follow-up, and his technique, he had a cross-link that he put in and then a tether, and he anchored it to and then tensioned the cross-link. What he found is that at 2 years with a tether, 0% had revision for proximal junctional kyphosis versus 35% if no tether was used. And so there's good support that the tether may be offering some benefit. My current strategy, I thread the tether through the interspinous ligament between the top two instrumented levels, and then I drill a hole through the base of the spinous processes, and I just weave the tether through, then I anchor it to the rods. There's a tensioning tower. Lots of companies now have systems like this. I helped design one of the first ones, but there are lots of companies that have it now. And that it seems to have made a difference. Is it the solution? No. I certainly have had failures. I don't think it's solved the problem by any means, but it may be a broader solution. We did a review, as Tolga Sirsal was our fellow from last year, and we did a review. This was an invited review, and found 15 studies on tethers. 14 of them were in favor of them as far as reducing risks of PJK, PJF. One showed equivocal rates of PJK and PJF, but the literature is supporting the use of tethers. So in this lady whose BMI is almost 50, we're probably going to want to take into account her junction and trying to reduce the risks of failure there. She's already failed. This is part of her problem is she keeps failing at her junction. So when we do another revision in her, we're going to want to try to keep it from failing yet again. Another one in risk factor for her is infection. She's morbidly obese. This would be the 9th surgery going in her back. So you can imagine her tissues are going to be just wonderful. So infection is going to, and she's diabetic. And so one of the things that I've done, I think a lot of spine surgeons have started doing is putting in some vancomycin powder, kind of prophylaxis. I thought it was a little bit of voodoo when I first heard about it many years ago, but then I started doing it. I think empirically it's made a difference. Doesn't seem to breed resistant bugs, which was the first concern. There's studies showing that doesn't seem to be the case, but I think it helps. And this is a review article or a systematic review from Ron Lehman with a pooled effects analysis showing that there is or appears to be protective effect of vancomycin powder just added prophylactically at the end of the surgery. The reported doses were all over the board. So there's no standardized approach. There's no standardized place of putting it. I'll put in 2 grams with my bone graft before I'll lay it out in the lateral recesses for fusion. But there's really no standardized way of using it. Chris Ames did a cost effectiveness analysis because anytime you add something new, it's going to add more cost when you're adding another implant. And so you put the vancomycin powder in every patient, you might only prevent a certain number of infections, but they calculated that out. And they found that per 100 complex spinal procedures, they're actually saving $250,000. So that was helping to offset the cost of that vancomycin powder. All you need is one patient who has a horrible infection and needs a washout and needs IV antibiotics. That's a lot of cost that pays for a lot of prophylactic antibiotic in the other patients. And also for what the patient's going through as well, too, just in addition to the cost. So in her, we're probably going to want to use some kind of antibiotic prophylaxis to try to reduce her risks of infection. The fourth one in her is malalignment. And that's what's kind of plagued her from the beginning, that she was probably fused a bit flat in the lower lumbar spine, and then they've just marched up her spine. This was a study we did. This was again was Elias who helped us with this one, looking at how good surgeons are achieving their goals through. So we did in the ISSG is we had surgeons before they enrolled their patients in this adult deformity database. They had to declare ahead of time, what's my goal alignment in this patient? What do I want to achieve for the sagittal vertical axis or the sagittal alignment? How much lumbar lordosis do I want to get? How much thoracic kyphosis do I want to get? And they could use whatever they wanted to do to plan their case. They could use sophisticated software that's available. They could just look at a PACS machine. They could just have general goals of alignment if that's what they wanted. But they had to declare ahead of time, what is your goal for this patient? What we found is that surgeons tended to overcorrect, to correct more than their goal in these patients. And all three of these goals, which are all important goals for alignment, they only met their goals in 37% of the cases. So it just tells us, and this is allowing them to choose their own goal. We weren't telling them this is what you need to achieve. This is what they were hoping to achieve, and they only achieved it in about 37% of cases. And we gave them a pretty broad target to hit. They didn't have to hit it exactly. Like we gave them some buffer around it, and they still was only 37%. Part of that is because we're not really good at bending the rods to angles that we think we can bend them to. And this was Juan Sardi, who was a fellow at the time, helped us with this. And we gave surgeons, a group of adult deformity surgeons, pieces of rod. And we said, okay, bend this to 40 degrees, bend this to 60 degrees, bend this to 80 degrees. Because you go into the OR and you'd be like, okay, well, I want to achieve 57 degrees of lordosis in this patient. When you pull out your French bender and you start bending, how do you know what 57 degrees is, right? It turns out we're not very good at judging what 40 degrees or 60 or 80 degrees is. We tend to overbend. But if you were given a template, if you're given a piece of rod that was 40 degrees, and we say, okay, bend it to 40 degrees, this is a template, they could do it beautifully. And so it suggests that there's some room for improvement in translating this beautiful plan that surgeons often have ahead of time for their surgeries into the OR, because there's this gap. You start out, you've got your beautiful plan, you can use SurgiMap or all this software, you know where you're going to put your osteotomies, you know what angles you want to achieve, but then you get to executing that in the OR, and you have pretty limited tools to actually make sure you achieve that. You can get long cassette x-rays once you've done your correction and see if it looks good. Maybe personalized rods. I don't know. I've had my experience with the personalized rods where they plan them for you and send them to you, is that I end up bending them a lot anyway. And so I don't know. Personalized inner body spacers where they plan out your spacers and angles and correction and all of that. And then there's all kinds of software that's being developed to try to allow surgeons to be able to look at what their alignment is on the table and try and predict what it's going to be when the patient stands up. But there's a huge gap there. That's a really a limiting factor, because if you don't get your patient aligned appropriately, they're going to have a higher risk of failure and needing revision surgery. So if we come back to Our Lady here, and we remember, just to refresh your memory here, she's got a lot going on. She's flat backed. She's got a fracture of screws here. Her screws are pulling out at the top. She's got a horrible stenosis here at the top with an ossified giant calcified disc. She's got a stimulator in place. And it's just to remind you of that. So what do you do for this patient? John, what about you? What would you do for this lady? It sounds like the kind of patient you get.
Yeah, I mean, ideally in a non-acute setting, you optimize them. Those steps you mentioned, their bone density, their counseling, getting them to lose weight, but if they come in an acute neurologic deficit, the question is whether to address just that short, that focal problem where it's causing the neurologic deficit versus the.
What would you do just to address? So say if you choose just you want to focus on the neurological deficit, how would you address that with the screws that have failed and the
body that's extend the fusion at least up to the thoracolumbar beyond the thoracolumbar junction, and do a vertebrectomy and remove the calcified disc, extend, revise down to the pelvis. The question is whether to restore lordosis in a lower lumbar spine where she's deficit in this.
So if you just extend her up 2 or 3 levels, do a lumpectomy, clean that out, what's gonna happen?
Not go up to T3.
But then you flat back her at T3. Is she gonna be happy with that? Any other thoughts?
L4 PSO.
Okay.
That's her origin of her problem.
So L4 PSO, and then what are you gonna do for the rest of her spine?
Take spinal cord stimulator out, do a decompression and discectomy at the junctional level where she's got the stenosis. 2 iliac bolts bilaterally. I'd like to plan and see if that's actually gonna get the alignment, but something like that, and probably up to T3.
Anyone else? Where would you take her for your UIV?
Yeah, upper thoracic.
It's a big surgery. What about you, Dr. Marcus? Check her for any. Well, okay, what would you do?
I don't know.
Flexible rods?
SCEG. But can you go back to that picture though? The single question I have for you, not the one you had originally.
Would that help you?
Which one? That one?
The patient that we were presenting.
This one.
These are the X-rays. Yeah. So, the big question is, how did you get this way, right? And I think you have to reconstruct what led to this problem in the first place. And there's kind of 2 problems, right? There's a loss of lumbar lordosis, but there's also a loss of thoracic kyphosis. And I think if you really want to restore sagittal balance, you got to fix both. Because without it, she'll just keep falling over the thoracic spine, even after you lordose the lumbar spines. So the PSO would certainly work, but I don't know what abilities you all have to restore thoracic kyphosis. That would seem to be a goal here as well. Anyway, I know I sound very, professorial here, no idea what to do.
But it's honest, I like that. But the part of the thoracic hypokyphosis here is probably compensatory, because when she's standing and she's struggling to stand, she's flattening her upper thoracic spine to try to stand. So you don't necessarily know how much of that. You can lay her down and get a little better idea, but I wouldn't necessarily assume that the thoracic kyphosis is lost there. It's probably hyperextension to stand up.
Postural in
Postural,
response to, yeah.
Yeah.
So in that case, I would just fix the lumbar spine and stop at the thoracolumbar junction.
Okay. So would you do a PSO? So how would you restore this? No, I'm not trying to put on. Yeah, so.
I mean, I think it's different in a different setting. I think, doing a large calcified disc, extending a fusion multiple levels and doing a PSO on someone who's not optimized, who's very sick.
Right.
Comes in with a incomplete, cord level injury is different than in the elective setting where it's where it's in a more controlled fashion. But yeah, she needs a PSO.
So what level is that calcific disc at?
12-1. So what I did, I took out the spinal cord stimulator. I think just the risks of arcing down through that are significant. So I take those out to start. I just did laminectomies at 12-1. Took out all of her metal and replaced it. I went to T9 and did an L4 extended PSO, so grade 4. And then I did supplemental rods, proximal tether, and Vanco powder. So kind of, this is her after. You can see she's better aligned. She's standing up. She had marked neural improvement, just quite dramatic. No.
You left that big.
Oh, yes. Oh, yes.
Why? Oh, yeah.
Well, part I think part of the problem is the cord was compressed against the lamina behind, and the screws at the top had wiggled loose and pulled out. So I think that motion of her cord dragging over that calcified disc is what was causing the cord compromise. It had probably been there for a while because it was calcified. So I stabilized and pulled her back and then decompressed from behind.
But you still got.
She still got it.
You got ventral compression
Yep,
on the cord, no
Yep.
matter what.
yep.
Why wouldn't you just take it out? Because you're gonna stabilize across that level anyway.
It's a matter of how much surgery you can put her through.
But the discectomy compared to what you did there, so not very, I mean, I just wondered.
No, but it's a big calcified anterior disc with an unhappy cord. And so, yeah, no, it's a good point. You could argue to take it out, but I've had experience where it's not necessary to in this kind of a setting.
Okay.
So, and she did well. She improved markedly. So you can say for revision risks, which is kind of the topic of this talk, we address risks of rod fracture, PJK, infection, and malalignment. And you can see her here. This is a talk about revision surgery. So where do you think she failed? How do you think she failed?
Depending on the core strength. Doesn't matter what you do, if you don't build her core strength, she's gonna end up being bad.
Oh, she did. Well, I mean, in these 4 months, she made dramatic improvement. She was like walking with a cane and she was dramatic improvement. So she was on her way to improving. So how many would say rod fracture? Yeah. I'm gonna say PJK. Yeah, well, there you go. Sometimes the crowd is right. She came in, she had a fall, and then she had mid-back pain, thoracic radicular pain, and again, lower extremity weakness and difficulty walking had returned. And she had developed a PJF, or PJK. And you can see that on her MRI and her CT here. Had questionable fluid collection, didn't know if that was infection or hematoma. So then what do you do for that, John? You heard it. What else? Anything else or no?
We had a vertebrectomy at that.
Yeah.
Not level.
Yeah. It's exactly what I did. So took her up to T3, which is what you said to do in the beginning. And she's now, this is a 1.5 years out. And she's a new woman. She's normal.
Is that in the proverbial, because she can talk and move, she's normal?
She's neurologically intact. She walks normally. She's a new person. She gardens. She was as happy as she can be.
It's only the first spine surgery that was not in the.
Well, the problem, I think, if you look back at this is the area that I really like because it's kind of like a post-mortem, if you will. I think that way back, they started out and they probably did a 5-1A lift, and she has no lordosis there. They didn't restore any of the segmental lordosis at the bottom. So then the 4 or 5 level has to hyperlordose to try to make up for that. And it just creates this cascade. And at none of the levels did they get any lordosis. And so I think it was a kind of this progression of a flat back that led to this. So, I mean, I don't know what the answer may have been to be more aggressive in putting in a hyperlordotic cage at L5S1, if that's what she really needed. And trying to get some lordosis down there. Our weight is a big factor too. I think that high body mass index is a setup for these problems. But yeah, questions?
Yeah, so I mean, we talk about sagittal alignment a lot. And one of the things that I never actually hear very much talked about is where the center of gravity is for the patient. But that actually does make a difference to how far forward the actual center of gravity of the patient is. And the larger the patient is, even if your sagittal alignment by your parameters are okay, the further the center of gravity is and the more overall stress forward there is going to be on the patient. I mean, have you heard about anything that, I don't hear anything about that talked at all.
Yeah, I mean, I don't know what the answer is though, because would you just overcorrect them to pull them back?
No, I was just wondering that it would be, I just think that it would be something to study because I mean, you would just overall by the stress of where you're being pushed, even if your parameters are okay, the bigger the patient is, the more forward it is, it's going to be pulling you forward. I mean, I think that.
Yeah, completely agree. And I think that's why BMI is one of the independent risk factors for junctional failure. It's that very reason. How do you solve that? I usually make my patients lose weight. You know, if they come in and they're a BMI of 40, I say, come back when you're less than 35. Even then, they're not small. I try to optimize them if I can. This is one where you couldn't, obviously, because she had to have surgery. But I think trying to optimize and get that center of mass more favorably in a more favorable position is worthwhile. But yeah, I don't know that there's a calculation for it. I just try to make them lose weight before doing a big elective surgery like this. Yeah, I don't have the answer for it, but I agree. It's, when we did this, we did the 5-year outcomes or 5-year from the NIH study. We looked at rod fractures in one paper, and we looked at PJK, PJF in another. And I think one of only 2 independent factors for proximal junctional failure in that series was BMI. So that seems to be a common recurring theme. But I don't know how you would change your alignment. You wouldn't want to overcorrect them because then they're going to be at higher risk of failure from overcorrection. So I think the only solution there is to make them lose weight first before undergoing a major elective surgery like this.
So how do you measure frailty? What I understand, the very frail patients are similar to the elderly, where they're higher risk, but they have a lot more complications, but do very well. So the risk is worth it. But there's a group that are very frail, where the majority of the complications are kind of clustered, and that's where the scales tip.
Yeah.
What is that?
That's a great question. We look at it through ISSG, where they've come up with they've used AI, and they come up with all these really complex calculations. And I think we don't have the tools yet. And it's one of the research goals for the SRS. I'm the research council chair for the SRS, and we just finished our round meeting with stakeholders, and that was one of their top priorities, was identifying high-risk patients. Chris Ames has that strong interest too, and through the AO, we're going to be looking at that as well. Looking at biomarkers, like telomere length. There's other factors, inflammation factors, to look at the state of the patient's health and their frailty. Frailty is hard to define. It's kind of like it when you see it, kind of thing. But I don't have the objective answer for frailty for you. Yeah. Yes.
The evolution of the disease, you're treating the endpoint of what happens. What do you think is the phenomenon? It's easy to understand maybe what happens with osteoporosis, with asymmetric collapse of bone. But in the average American who's going to end up in this situation, is it some degeneration of the disc that leads to asymmetry or whatever? And then what is the natural evolution that ends up to this? Because you're treating the end result. We ought to be really looking at what should be done to prevent this end result if we could. What do you think is the phenomenon?
I think it's aging. I think it's asymmetric wear of the disc and the facet that starts to cause the spine to tip. And then that once you start getting a little bit of an angle, then it's even more stress loading asymmetrically, right? And it kind of cascades.
Is it because the human spine and in the erect position is only able to have 60,000 miles on it before that occurs?
I think so.
Or is there a nutritional or like as Jesus said, some sort of range of motion exercises or whatever you could do to prevent this or what?
Well, I think good health is important. I think keeping your paraspinal muscles, keeping fit is important. One thing that's interesting when we do these studies, especially for the scoliosis patients, degenerative, it ends up being that 80–90% of the patients are women. So there may be some biological clue to it. And if you look at adolescent idiopathic scoliosis, probably 90% of them are girls. So there may be biological things that are at play.
We've only been upright for 2 million years.
Right, but we haven't lived to be 70 or 80.
That's why I wonder if it's just not.
Well, what I just mean is like
If you died at 40 or 50, then you don't.
We're the only animal that walks upright, and it's only 2 million years old. So our spine is not going to last 200 years of age. It's just not gonna.
There's no evolutionary pressure. You believe in evolution? There's no evolutionary pressure on this.
We do believe in evolution.
You've already reproduced by the time you develop this problem, right? So, yes.
Are there any documentation or guidelines for, length of stay or readmission criteria or any documentation that would account for these complex patients compared to a TLE for how does Medicare or how, in terms of VCN scoring or how do they calculate your length of stay or your readmission? or your complication rates for the hospital metrics for these complex patients?
Well, I think, I don't know, is the short answer. I don't know how the hospital's calculating it.
There isn't
They're
a,
looking at DRGs, they're
Yeah,
looking at
you see-
comorbidities.
the DRG for a one level T-lift and for a 20 level, fusion with osteotomy is not that different from each other. So,
Which is a major problem.
It's, yeah, no, I agree with
it's a
you.
reimbursement problem, it's a length of stay problem, it's all of those.
Yeah, you're not getting the amount of credit you should for this complex of a case. So when you're adjusting for risk, I don't think you're actually getting as much correction as you should for this type of case. I agree. But I can't change that. I'm only one.
Well, that's something that should be probably, lobbied or.
Exactly. There's pressure for that, but that's not something easy for, to change. But I agree. Yeah, this patient, that's why I think she's a great example of what can you do to try to not make her into someone who's gonna be having another 20 surgeries after this one. I had to do one more, but hopefully knock on wood, that'll be the last.
Thank you.